Let's crack on with the final session. Thanks for so many of you hanging around for this session, because I know it's quite tempting to leave after afternoon coffee. It's great to see so many people have hung around for this, because 3 really good presentations and just show some of the great work going on in our research side of urology. Okay there? So we've got, the way we're going to run this session is three presentations, 2 by Craig you've already met, 1 by Martin, who you're going to meet in a few minutes, and then whilst this is going on, there's going to be an award. Someone will be working out, well, there's 2 people, Maria and Molly, will be working out a prize, because one of these 2 guys is going to win a small prize for their efforts. But it is really just more this to listen to some of the great work going on and give the trainees a forum to show their work. So without further ado, let's bring up Craig, who you met before. He's going to talk about upper tract urothelial cancer.
So thank you. I'm presenting this work on behalf of Jack, who's on his way back from Glastonbury, which is why he's not here, but also Peter Smith, who we devised this project. And so it's the first time it's been presented, really. So we looked at the endoscopic and radiological follow-up of upper tract urothelial carcinoma in accordance with the Greater Manchester Cancer Guidelines. So just a bit of an introduction. So this is what it looks like under the microscope, but it's a very aggressive cancer, which if untreated leads to increased or decreased mortality and increased morbidity for patients. It's the urothelial carcinoma is the 6th most common cancer. 95% of them occur in the bladder, but 5% will occur in the upper tracts, with the common sites being the ureter, renal pelvis. So as I say, it's only in about 5 to 10% of patients with urothelial carcinoma. So as with all cancers, we use the TNM staging, and essentially goes from 1 to 4. And this helps to determine the risk of the cancer in terms of risk of recurrence. And the gold standard is to perform a radical nephroureterectomy in patients with high-risk, non-metastatic upper tract urothelial carcinoma. This, you will probably all be familiar with, is the surveillance protocol for patients who've undergone a radical nephroureterectomy, F standing for flexible cystoscopy and CT obviously being a CT, and it basically shows that the frequency, depending on whether you're low grade or high grade, it's not the easiest to follow. No criticisms of GM cancer here. But this is just a schema which shows that what you should be doing at each for high grade patients at 3, 6, 12, 24, 36. And this is what we audited against. So patients had to have had a surveillance procedure at the different time points. And then for low grade, as you'd expect, lower risk of recurrence and therefore a slightly lower frequency of surveillance. So we retrospectively reviewed all patients who'd undergone a radical nephroureterectomy at a high volume single centre over a 5-year period. And we excluded patients who didn't, or who had local follow-up, i.e. they'd been referred into the tertiary centre, had their treatment, and then been discharged for follow-up locally. So there were 112 patients who underwent a radical nephroureterectomy, and we excluded 58 of those because they received follow-up locally. So of the 64 patients, 55 of them were high grade, amounting to 86%, and a smaller proportion were low grade. And that may be because some patients with low grade TCC might undergo conservative treatment or endoscopic treatment. And as I've shown before, the gold standard is for high risk, high grade patients. So if we look at the endoscopic follow-up, this is a radiological follow-up for low grade. The majority of patients, as shown in the green, actually underwent the surveillance scan at appropriate time points, with only a very small number not having the appropriate imaging. If we look at cystoscopic follow-up, however, just over 50% received their early cystoscopy at 3 months, and it was fairly variable, and it was only when we got to lower numbers later on that actually patients were still having the follow-up. And we've removed patients who've either recurred, relapsed, or have died during follow-up. If we look at high grade, so these are patients who are much higher risk of recurrence, we can see that there's a significantly greater proportion of patients who aren't having surveillance imaging during the follow-up period. And that's even more the case when we look at cystoscopic surveillance. So actually, only 30% of patients at 3 months who should have had a cystoscopy had their cystoscopy. Not brilliant. So if we look at the recurrences, 15 patients had a high grade, so this is a localized recurrence in the bladder, so 15 patients had a recurrence. So that's a recurrence rate of about 30%, which is in keeping with the literature. Low grade, interestingly, it's small numbers, but there was a high proportion of patients who'd had a recurrence. Now, one thing to consider is that urothelial cancer occurs in patients who've got other clinical risk factors, often associated with smoking, heart disease, and so forth. So actually weighing up the benefits of a surveillance, is it going to change in management? And actually there was a reasonable proportion of patients who died during follow-up. Now, some of these were cancer-related deaths, but others were due to competing comorbidities. So in conclusion, we show that follow-up of patients following radical nephroureterectomy was overall poor in line with the GM cancer guidance. Recurrence is common, and therefore we need to strictly adhere to surveillance guidance, both endoscopically and radiologically, in order to best care for patients. Now, although it was a 5-year retrospective cohort, COVID-19 may have played a part in patients not attending for either scan or for flexible cystoscopy follow-up due to the strict measures in place. So what we're proposing is that we present the results. We raise awareness of the surveillance schedule, and rather than a tabulated table, which may not be easy to follow, actually each individual patient could be given a proposed timeline, so when their visits are going to be and what interventions or surveillance they should have at each time point. And then we can reevaluate in 18 to 24 months, because it's those early cystoscopies that really are key, because we know that if they do recur, they recur early. So I'd just like to acknowledge that it was a team effort. So here's Jack and Peter who couldn't be here. Thank you.
So I'm not going to ask any questions myself. I've asked too many. Any questions from the floor? Now's your chance. Put these trainees under the heat. Come on. No one wants to ask a question? Oh, here we go. A question, Maria. Go on, Maria.
I think it's quite interesting. I was just thinking, and I think it's also important, the suggestion that you gave about empowering the patients and somehow letting them own a bit of the responsibility. But do you have any other ideas on how we can improve the follow-up for this group of patients?
I think one of the challenges we've got is capacity, really, and everyone's fighting that, and it's about risk stratifying, and often patients who have had their treatment aren't necessarily on a pathway, but given that 30 to 40% of them will have a recurrence, and if untreated, that recurrence, if they're high risk, may go on, and become invasive and potentially metastatic, I think. So it's bladder cancer and urothelial cancer in general has always been a challenge as to how patients fit into the current pathway models. Prostate cancer is very different, and actually the majority of men we treat with prostate cancer don't die from prostate cancer. TCC is a very different beast. And if we can kind of try and emphasize the importance that actually following a strict evidence-based surveillance protocol is as important as getting patients to their diagnosis and treatment within 62 days, then I think we might have some way forward to bettering that. But yeah, I think it's a real challenge, and if you've got any suggestions, let us know.
Yeah, I mean, I'm just remembering back about 10 years ago when I used to do nephroureterectomies and things. We were very poor at doing CTs at all for any patients at that stage. It was very ad hoc. So we have made some progress, but clearly some room to go. Can we move on to next presentation, view of time? So Craig, again, speaking on behalf of a different group this time about a proposed model to assess the accuracy of diagnostic stage and grade in prostate cancer after an audit. So there you go, Craig.
Thank you. So yeah, moving disease groups, but still in the cancer realm, very definitely. But what we wanted to do was to evaluate diagnostic stage and grade in men undergoing radical prostatectomy in a single tertiary centre. So we know that through efforts of the Greater Manchester Cancer and the Cancer Vanguard, this best time pathway for men with suspected prostate cancer, all men should be getting an upfront MRI prior to biopsy, because not only can it help deter patients who don't necessarily need a biopsy, who have a kind of low risk of clinically significant cancer, but it allows us to target areas. And then it can potentially be used as a staging modality to help risk stratify patients. This is what an MRI, for those of you that don't see them often. So this is the prostate centered in the pelvis. And what it allows us to do is to look for areas of abnormality. And radiologists will report using a standard PIRADS or Likert system. And then often they'll give a radiological stage, but actually the guidance is based on clinical stage, which is by digital rectal examination and not radiological T stage. But there has been a shift towards using the radiological T stage as the gold standard, but that isn't what all the trial evidence is based on in terms of risk of recurrence and risk of needing further treatment. And then, as well as the stage, we can use the grade. So the Gleason score is then used. And commonly now we know that Gleason 7, actually there are two subgroups within Gleason 7. And that's the ISUP or ISUP grade, which separates Gleason 7 into ISUP grade group 2 and ISUP grade group 3. And they have very different outcomes and help to determine who best will benefit from treatment. So we evaluated the diagnostic stage using the MRI or DRE, the diagnostic grade, and we compared with the final histology. So we looked at patients who'd undergone radical prostatectomy, and that is then used the gold standard because a needle biopsy is only going to provide a small sample of the prostate tissue. It's not the entire prostate tissue. And equally, the MR scan will give a hint to the stage, but the final stage is a pathological stage, which is from the prostatectomy specimen. We then assessed correlation using a Kappa coefficient, and we were able to then sub-analyze, due to the fact this was at a tertiary centre, we could look at studies from referring institutions. So as with any audit, we did our first cycle and we presented the results to the Pathway Board a couple of years ago, and then this is showing the additional of our cycle 2 results. So cycle 1 consisted of 96 patients across the 3 main referring sites with a slight preponderance at site 1, but generally reasonable numbers across all 3. And due to it being over the same time period and not much had changed, no one's found a cure for prostate cancer. So 92% of patients versus 96, and again, a slightly similar spread across. Now, what we're seeing here is a bar chart showing proportion of patients of the total cohort who either had downgrading or upgrading, and downstaging and upstaging. So what we saw was that 12% of patients were actually downgraded. So that's where their ISUP grade group went from a 3 to a 2 or a 3 to a 1. 18% of patients had an upgrading. So that's where it changed. It went higher. So it was either a 1 and moved to a 3 or 1 to a 2. And then similarly, we saw quite a significant shift in terms of T stage, with 20% of patients being upstage. So they'd gone from potentially localized disease to locally advanced disease. And that has significant implications as to how we counsel patients. In terms of agreement, it showed moderate agreement for grade, fair agreement for stage. Now, that was fed back to sites. And then when we re-audited it, what we actually saw was, again, even more heterogeneity. So we saw 20% downgrading, 16% upgrading, so nearly 40% of patients had a change in their grade from diagnosis to final histology. But interestingly, in terms of stage, over a third of patients were upstaged on their final histology specimen. Now, what we can then do is actually look at it across the network, and this is just a proposed model whereby actually you can plot all the different institutions. You can look at their correlation for grade and stage and then compare them, not necessarily to the gold standard, because you're never going to get it 100% right all the time, but you can compare sites to each other to see if there are any outliers. And what we see is that there may be potentially outliers that, through feedback, you can potentially address these issues. And we saw that both for grade and also for stage. And if we look at just the clinically relevant changes in grading, and that's in patients typically who have intermediate risk prostate cancer who we're either going to survey and manage with surveillance, or we're going to treat with radical treatment such as radiotherapy and surgery. And we can see that there was a significant variation just across GM, with 9% downgrading in one centre versus over 20% downgrading in another centre. And with staging, again, we saw that 31%, but one site was actually upstaging patients on radical prostatectomy, nearly 1 in 2 patients. Now that has quite significant effects to patients. The strength of the study, well, we had a single pathology department that were reporting the final histology. And there's real potential here that not just in GM, but if you enrolled this out nationally, then you'd potentially be able to identify outliers. And there was limited missing data largely due to electronic patient records across GM. Now, limitations, these were only patients who underwent surgical treatment. We don't have data, obviously, for patients who underwent radiotherapy, but you'd have thought that if they were being treated radically, you could extrapolate the results the same across them. And it's only for the 3 referring sites across GM, and there are obviously many more centres in GM. But what do we think? So individual site review of discordant data can provide useful feedback to relevant teams to evaluate their standardised reporting of both radiology and pathology. And if we can embed standard setting in prostate cancer diagnostics in urology, radiology and histopathology, and we can do this through not just regional but potentially national collaboration. So in conclusion, we're proposing an audit framework in which we can identify variations in diagnostic stage and grade, and that if applied nationally, this model could identify potential outliers, and through feedback to these sites, we could help improve accuracy of diagnostic staging and grading. And this might potentially avoid both over and under treatment and help better counsel our patients. Thank you.
Excellent, really good audit where there's been a re-audit, so really, really good, and some interesting messages. Any questions from the floor? Really keen to take a question from somebody. Yes, we have a question. Thank you.
So basically the re-audit showed that the anomaly was far higher than what you expected. So what would you do? I mean, if you get such a result, I mean, where you're planning to do something good in the audit, and then it hits back and then comes back to us showing that whatever change we brought has not had the impact.
I think it just shows that feedback can influence people's decision. So if someone's told that they're continuously overstaging or overgrading, they might go too far the other way potentially. And I think that's the importance about having a reference standard to say, well, actually, what is good enough? And actually, if we're calling it right 4 out of 5 times, given the variability in pathologists, so the PROMISE trial, which looked at MRI reporting, and actually this was led out of a large tertiary centre in London, there was still significant heterogeneity among the reporting of MRI scans within their expert radiologists. So I don't think as a site you can expect to get it right 100% of the time. But the point is, it's knowing how you're performing as a unit compared to your peers down the road or compared to your peers nationally. And if you're consistently undergrading or understaging or vice versa, then that has implications. And actually it's the identification of an outlier that's the key metric. But I think it also highlights that we should probably be having more collective. I know certain sites have a prostate planning meeting where the surgeons will sit down with the radiologist, pathologists, they'll mark up the specimen, they'll review the pathology from the previous one with the radiologist so that we can improve our accuracy. We're all learning, we're all trying to do what's best for patients. No one's getting it, not wrong, but no one's inaccurate on purpose. Everyone wants to try and be better, and it's just trying to provide the framework for that.
Was it single reading or were there 2 radiologists reporting? I mean, in terms of radiology, was it like a...
This is an MDT, so it depends on how the MDT reports. So you might have a reporting radiologist, but then it goes through the MDT process, and sometimes there is change. But this was the MDT stage that we compared to.
Thank you.
Okay. Thanks. Okay, and finally, we have Martin Swinton, Oncology Research Fellow. Martin, the floor is yours. Thank you.
So hi, thanks very much. So I've just got a couple of minutes to talk a bit about some prostate cancer research that's happening at the Christie Hospital and is sort of available to patients, involving patients with prostate cancer across Greater Manchester. So this is a 2-arm trial called the Hypogen trial. So we're very interested in the role of hypoxia, so low levels of oxygen within the tumour, within prostate cancer, and the kind of implications for that for patients and their treatment. So we know that in cancers and in prostate cancer, you can get these cells that get low levels of oxygen, either because the cancer grows away from the blood vessel and it becomes you get this chronic hypoxia where it's a long distance from the vessel, or because these blood vessels within cancers are typically quite irregular and kind of poorly formed. So you can get blockages, so you can get this what's called like an acute hypoxia as vessels block. And the reason that we think it's relevant and important is because it's been shown in a number of studies that if you measure the levels of hypoxia in prostate cancer, those patients who have more hypoxia, so more regions of low oxygen, they do much worse. So after radiotherapy or after surgery, more of these patients recur or and die. And that's particularly if it's associated with so within the tumour, if there's sort of genomic instability, this is a group of patients who do much worse. But we don't use any, in sort of our standard care, we don't ever know the hypoxia status of our patients. It's not something that we sort of routinely look for or measure. And that's partly through the kind of ability, how we measure it. So in research, in the research setting, people have measured hypoxia in a number of ways. So there were some studies in the sort of 2000s where they directly put that sort of electrode probe into patients' prostates and actually made lots of readings of their prostate, and you can get the actual exact oxygenation level in lots of areas. But that's invasive, and it's difficult to scale that up to to kind of do it routinely. Another way is if you can get like tissue from the patient, so either from their biopsy or when you take out their prostate, you can look for markers that show that a region's got low levels of oxygen. So the one I'll mention, because we're using it in our trial, is if you give patients this tablet called pymanidazole, this is a tablet that in a cell that's got a low level of oxygen, it goes through a chemical change of reduction, and then it gets kind of like retained in that cell. It forms bonds to compounds within that cell. So afterwards, if you get, as that image is showing in the top right, you can use an antibody. You can sort of stain the regions that tells you that at the time that was taken out, that region had low levels of oxygen. You can also look at like gene signatures. So you can, if you get some tissue from the prostate, you can also look at levels of RNA, and there's differences in hypoxic and non-hypoxic regions. But again, this is difficult to do routinely because it's expensive, and again, you have to get tissue from the patients. So a possible promising future technique we could do to know about patients' hypoxia status is we could get imaging. So there's been some work looking at either MR scanning or PET scanning to find regions of low oxygen in patients' tumours. And I think we're particularly excited about this at the Christie at the moment because we now have the MR Linac, which is a way to give radiotherapy with an inbuilt MR machine. So we could potentially be if we could kind of validate that these sequences actually work, we could be using this in patients before and after radiotherapy and sort of identifying patients with low levels of oxygen in their tumour and thinking about ways to adapt and manage them. So in the Hypogen trial, we're looking at two groups of patients. So we're looking to, the sort of aim of the trial is illuminating the genomic landscape of hypoxia-driven early metastatic prostate cancer. So our hypothesis is that the reason these patients with hypoxia do worse is because that being in a hypoxic environment makes the cancer cells kind of go through those early steps towards metastases, so things like invasion and spread. So within the Hypogen trial, off the first arm of the trial, we're looking at patients who've just been diagnosed with metastatic disease, and we're asking these patients, so they would normally have a prostate biopsy done at their local hospital. They're coming across to us at the Christie instead and having that biopsy done with us after they've had this tablet, the pymanidazole. And they're also having an additional a bone biopsy, so a biopsy of one of their metastatic lesions. And so this way we have from their first diagnosis paired biopsies of both their primary tumour and a metastasis, and we are knowing where the regions of low oxygen are. So we're in those samples, we're going to be looking for genomic and RNA changes that happen within the regions of low oxygen, and to sort of we think to demonstrate that it's those regions that throw off metastatic lesions. And then, this is just one of our example patients. So in that arm, so this was the man who was in his 50s and went to his GP because of lower urinary tract symptoms, had a PSA of 75. He had a CT and bone scan, and as well as an MRI, and he had this tumour within his prostate invading into his seminal vesicle, as well as a number of lesions within bone. So he came and had his, after having pyrmanirazole the night before, had his prostate and biopsy done at the Christie, as well as this, had a biopsy of that lesion on his pelvis, which is just, oh no, I can't show it, but just there. And so this is just showing, from one of our patients where we get these kind of biopsy cores from the prostate, and we're collecting these and we're sending them now for what's called spatial transcriptomics. So that lets you look at RNA expression across kind of regions of interest. So you can see in an area that has high level of oxygen and low level of oxygen differences in RNA expression across the tumour. And then in the second arm of our trial, we're looking at a different group of patients. So these are prostate cancer patients as well, but these are men with localized prostate cancer who are coming to have their prostate removed. Again, what we're doing in these patients is asking them to take this drug pyrmanirazole the night before their surgery, so we can see which regions have got low levels of oxygen. And then in these patients, we're getting a scan on either the MR-Linac, which is that MR machine with a linear accelerator to give radiotherapy, or just our sort of standard diagnostic MR at the Christie. And we're doing these hypoxia sequences, it's a kind of like a 55-minute sequence, which has got a number of, it's like different sequences to what you'd normally get in your standard MR, but they're all thought to pick out low level regions of like low levels of oxygen versus normal oxygenation. But what we can do in this trial is, because we're going to have the prostate taken out just after their surgery, we can actually validate, so we can say, if the scans suggest that there's a level of hypoxia there, is that true? Is that real? So the idea is that we'll validate these MR imaging, these kind of markers of hypoxia on the MR, so that we could use these we could look towards using these in more routine practice, or certainly within trials. One of the challenges we have, I just thought I'd have some pictures of prostates here. So this is I guess that the challenge we have is that when you take out a prostate, if you want to say, this region I see on the MR scan that I think's got low levels of oxygen, how do you, when you've now got this bit of tissue, how do you say that's in the right place? And so what we're doing with the way that we're kind of doing that is we're creating a patient-specific mold. So with each patient that comes through, we're getting an MR scan, we're contouring, we're drawing around their prostate, and they get this like personalized mold, which after their prostate's taken out, it fits in. And that way, we should know when they kind of cut the prostate, as they standardly do for diagnosis, we know exactly where we are on the MR image. So we should be able to say, this region of the MR that says it's hypoxic matches this bit of your prostate that we've taken out that we've proven to be hypoxic. And this is just to show one of our first cases. So these upper images are you've taken out someone's prostate, and then they kind of cut it this way. And the image on the top left is showing the sort of standard H&E staining. So this patient's got two tumours within the prostate in the transition zone on the left and right, which are outlined. And that the right side image is showing that pyrmanirazole staining. So that essentially tells you that brown staining is saying that region is hypoxic. So you can see that both tumours are more hypoxic than the kind of background prostate, but the tumour on the left side has got more hypoxia compared to the right side. And then these images on the bottom are our MR images. So the middle one is looking at diffusion, which is kind of like how dense the tumour is at that level, and the one on the bottom left is showing contrast imaging. And so what our plan is to match how well these different sequences are picking out these regions of hypoxia. So in theory, you could, without taking out patients' prostates, you could pick out those hypoxic regions in future. Obviously, this is a collaboration of of well, lots of people, including a lot of people in this room. I've just decided to say thank you for all those people. I'll stop taking questions.
Okay, any questions? A bit more of a complicated study here. Yeah, Jeremy, thanks.
Hi, Martin. Sorry. As you probably realise, my name is on there, so I get the specimens from Martin. But it's just a question that's been going through my mind with the hydrogen 2 part.
Yeah.
So that's the bit where we get the radical prostates out and look at them afterwards. Obviously, when I disconnect the prostate, it's hypoxic. So does that have you any way of working out how the time from when we've disconnected to the time you getting the specimen makes a difference?
That's a really good question. I suppose we are seeing a differential between. I suppose there is a time for I suppose for the pymenidazole to go through that chemical change, stain, and so we think it's actually because they're taking it like the night before, aren't they, at about sort of 9 p.m. So actually, I suppose we're thinking most of that kind of accumulation and staining is across that time. But I guess there is an effect of, as you say, you take out the prostate and it should all become hypoxic. I suppose this has been a method that people have used, multiple trials before. I don't know how you would check. I don't know how you would compare what how would you check? Because how do you know what the pymenidazole is looking like?
I was just wondering if you had a feel for it. To be honest with you, because when we've taken out the high risk ones, quite often we still take lymph nodes as well. Now the way I do mine is I do the prostate first, disconnect it, leave it to the side, and then do the lymph nodes. But that adds an extra hour or so to the case. So there's potentially an hour where the prostate's sitting there, hypoxic. So just for you, I changed my practice. Okay. So when we got these specimens, I was doing it the other way around. But it's just intriguing to know if it does make a difference or not.
Yeah, I mean, I suppose the fact that because I guess if the whole prostate was pymo staining, it was you'd think it's not picking out anything, but actually it's the fact you're getting a differentiation because as soon as you cut the blood vessels, all of this must be becoming hypoxic, mustn't it? But it's only those tumour regions that have stained. So I think it's just the time it takes for the pymenidazole to accumulate. And
can I just say to everybody in the room, this one and the last presentation are just a really good example of what GM is doing well, because this is working from networks. We've got multiple hospitals involved in getting these specimens, and we had multiple hospitals involved in the last one as well. This is what GM can do really, really well.
Absolutely.
Okay, thanks very much.
Thank you.
So we've got the panel working in the background, looking at the 3 presentations, and the results will come through in a second. I just want to summarise, if I can, some of the themes of the day. I think it's been a great day. Thank you all for coming. Thanks particularly for hanging around for this last section. I think it shows that we're ahead of the game in many ways, as we've just heard there from Jeremy. I think there's still a lot of work to go on. I think there's profound questions about our structure, how we set ourselves up, the impact of networks, and what we're going to do about our workforce. So the kind of themes, I've got about 6 or 7 themes I picked up today. I think we all need to go back and have a real think about what our units are doing. Have we got good urology investigation units? Are we doing as much as we think we can do? And can we train some of the staff in our units to have more enhanced roles, help their morale, help the department develop and give us more resilience? So I think there's some questions there, not least we're hearing that you might be overburdened anyway, but is there some way we can look at our workforce and develop things? And there's things like the academy and other resources for GM cancer can hopefully help that. We heard from Kieran that, and some other facts that we spoke about at the start, that we've had quite a reliance in our planning on where cancer surgery is. But noting that cancer surgery is flatlining in terms of numbers, but yet the cancer workload is growing, we need to also be mindful that we need to design our services around diagnostics for cancer and some of this other more sophisticated stuff that Andy pointed about before. We had a good discussion about how the workforce should evolve. It's a big challenge. We thought that we should have some new roles, but perhaps simplifying things and also trying to make sure that we're recruiting people that we'd like to join our services, getting new skills, and in particular bringing primary and secondary care together a little bit more were themes of that second session. We heard from the Pathway Board, which many of you in this room are members of, that it's very active. Loads of stuff going on. It's one of our most productive pathway boards, and I thank you for that. Some great work on prostate cancer case finding that we've heard so much about today. I really like the concept of patients testing their own blood for PSA at home and sending the results in. That's something that Manchester's leading on. I think it's a great initiative. Nurse-led prostate biopsy and some of the other stuff as well, really cutting edge, and I think that's great. So fantastic, and keep on the good work. I think we heard quite a lot today about acronyms and communication. Too many acronyms, and that's going to blunt communication between professionals and also discussions with our patients. So if we can start trying to simplify some of the acronyms we use, it might help. We heard this afternoon from Maria and Andrew about different oncological developments, quite a lot about brachytherapy, best thing since sliced bread, we heard. But size is important. I hadn't quite appreciated that small prostates were particularly bad, but there's some kind of pointers there towards which patients might be most appropriate. And Andrew's presentation, certainly for me, particularly asked profound questions about the degree of specialisation that is really afoot in urology and urology prostate cancer, for example. So how are we going to make ourselves fit for purpose in the future, and the impact of genomics. I have got the results back in now from the trainee presentation, so thank you for Martin and Craig. I can announce that the winner, and we'll just have some applause please if we can, is Craig Jones for the biopsy and stage. The proposed model to assess accuracy of diagnostic stage and grade. The prostate cancer one is the winning prize. So Martin, you're still runner-up, still good for your CV. So thanks both for those presentations. So in terms of a certificate, there's an online survey. It will come out in the next 1 to 2 weeks. Please fill that in, and then there will be an automated certificate of attendance that will come from that. Finally, can I thank you all for attending today and making it such a good day. Also, thanks, of course, to Ipsen, MSD, and Pfizer. So thanks very much. Home time.